NCAN used to play great pranks with me, and post lunch session I used to give talk on carcinoid diarrhea. Luckily they stopped doing that to me. So this is probably the funnest portion of NCAN meeting personally for me, where I like to interact with the patient, the audience, questions. Of course, we might not be able to give very case-specific answers, just a disclaimer. We are not allowed to give medical advice in this type of forum, but this will be considered like your friends, and this is more educational, like interaction, and we'll try our best. And I'm lucky to have two of my distinguished colleagues with me, and we're going to tag team it, okay? Based on everybody's expertise and interests, we can then try to answer. I'll try to moderate this session. If there are more questions, please feel free to write it down for us, and we can continue to take as many as time allows us, okay? Wonderful. All right, let's get started. Somebody has a beautiful handwriting. All right. How do you know when it is time to move to a different or new treatment? Dr. Del Rivera, why don't you take this one?
Okay. Yes, great. Well, thank you so much for the question. And so how do we know when we need to, when a patient needs a different treatment, a new treatment? And it's usually based on growth rate of the tumors. If we see, like, for example, if a patient is on lanreotide, for example, that's usually what we recommend as a first-line therapy for well-differentiated neuroendocrine tumors. So we start with lanreotide, and then on scans, we see growth of the tumors, then we make the decision whether we need to stop that therapy and what other therapy options we have. In terms of, like I said earlier, we have dysfunctional tumors, small bowel neuroendocrine tumors, we have some pancreas, functional tumors from the pancreas. So in those situations, usually we continue lanreotide because lanreotide has two functions. One is to control the symptoms related to hormone excess, but also to control the growth rate of tumors. Now, if the question is like, well, how long will that be? Every patient is different. Some patients can be stable on lanreotide for years. So I think that's something that we need to keep in mind. It's always important to discuss with your doctor about when is the appropriate time to stop therapy. So like I said, summarize, is that first line for well-differentiated neuroendocrine tumors is usually lanreotide. If we see growth of tumors, then we can make the decision at that moment whether we need to change therapy. We keep lanreotide if the tumors are functionally. We usually stop lanreotide if the tumor is non-functional. And then the other option is like, what options do I have? So in those options could be Lutathera, it could be capecitabine temozolomide, it could be everolimus, it could be cabozantinib, and that's something that we need to discuss with the physician based on what is the, and those decisions are usually made based on how many tumors we see in the skins, whether they express the receptor, what is the growth rate of the tumor, whether it's more rapidly or more slow growing tumors, whether it's a lot of tumors where we need to shrink tumors, or maybe chemotherapy will be a better option. So, but those are the things that you need to keep in consideration in order to decide what therapies and when to switch therapies as well.
I'm going to give a shameless plug here. So if you Google how to sequence neuroendocrine cancer therapies and put my name or Dr. Del Rivera's name and put cancers, CANCERS, we, 4 or 5 of us, net specialists from all over the US, we wrote a paper together with anecdotes and simplistic kind of explanation how to sequence and when to change therapies. Please give it a shot. It's open access, so you don't have to pay anybody to watch that paper or read that paper. And we've kind of given examples with references, like Dr. Del Rivera mentioned, when to switch to PRT, when to switch to other treatment, how do we decide between surgery or liver-directed therapy, etc. and etc. So definitely check that out. Moving on, there are a lot of questions by this person with wonderful handwriting. So, but I'm going to mix and match and come back to the other questions. For Dr. Vigayawala, for midgut tumors, can you just remove the tumor as an option, or is it always a resection? Maybe you can clarify when you are thinking about surgery. Do you always, like, I guess in pancreas you do have that option of just enucleation, but in gut, do you always have to do a larger resection with lymph nodes and all those things? How do you approach this?
Well, for midgut, we're usually talking about, oh, can you guys hear me?
No.
Small.
No, that's just the
Recording.
microphone for recording.
So for small, I don't know if it's on.
No, I don't think it's on. No, that's not on. Oh, yeah. Okay.
Okay, we'll share. For the option to remove just the tumor and leave the bowel behind, it is an option for some neuroendocrine tumors. But for small bowel neuroendocrine tumors, the tumor is usually within the wall of the tumor. Sometimes you can palpate it, but you may not see it on the outside surface. In that image that I showed of the patient who presented with the telescoping of the bowel, you couldn't actually see a tumor. But when we examined that portion of the intestine, you could feel the nodule there. And so you do have to remove that portion of the bowel with the tumor there, as well as its blood supply. So that sort of leafy tissue called the mesentery that contains the arterial blood supply, the venous drainage, and then the lymphatic drainage of that portion of the intestine. And so that needs to be removed and then reconstructed, so that way the remaining intestine has appropriate blood supply and can live healthy after surgery. So for midgut nets, a portion of the intestine should be removed along with it. Removal of or enucleation procedures for some small pancreas tumors is appropriate, and for some well-differentiated tumors of the liver, you can do that scooping out method that I talked about, or enucleation, where you're leaving behind the healthy tumor and leaving behind the healthy liver and just taking out the tumor.
Mm-hmm.
By the way, did I tell you guys that Dr. Vigayawala would be joining our group? So amazing.
Yeah.
Thank you.
All right, next up, I think this is a good question for Dr. Del Rivero. Mm-hmm. What do we know about the etiology or risk factors? Why do people develop these neuroendocrine tumor and neuroendocrine cancer? And the reason why I say she's a good person, because Dr. Del Rivero is actually leading one of its kind study at NIH called a natural history study, where patient can donate their tissue, they see the patients there, they fly them in, I don't know wine and dine part, but fly them in, they do all sorts of blood tests, tissue biopsies, scans, and they are trying to really understand the molecular underpinnings of neuroendocrine cancer. And what they learn at NIH will really help advance science throughout the world, our understanding of this. So she's probably the best person to tell us about what causes this. Have we figured this out, Dr. Del Rivero?
Thank you so much, Dr. Chahant. That's an excellent question, and that's the reason why we're doing what we're doing as well, to understand more about the biology of these tumors. So in terms of causes of what cause neuroendocrine tumor, during my talk I mentioned that less than 10% of neuroendocrine tumors may be familial. So patients that have a germline mutation, meaning germline when it's in every cell in the body, compared to somatic, because I think it's important whenever we see genomics. So what does that mean? So we have germline mutation, so meaning that it's everywhere in the body, in every cell, and there is a risk that your kids can have the mutations. And somatic is only in the tumor only, and your kids will not be at risk to develop any neuroendocrine tumor. As I say earlier, less than 10% has been a familial syndrome, so that we know that the patients that have that mutation will have a risk to develop neuroendocrine tumors. And which one are those? Those are the MEN1, the von Hippel-Lando, the neurofibromatosis type 1, the tumor sclerosis. So that's kind of like the most common syndromes associated with neuroendocrine tumors. Usually it's not by itself, so we have other clinical manifestations that make us think like, oh, this patient may have a MET1 or this patient may have a VHL. There is another familial carcinoid. So at the NIH we have a study where we're studying the familial carcinoid. That's not very common, but we have seen kindreds of family where we can see this familial carcinoid. And usually what we have seen, if like your mother or your sister may have neuroendocrine tumors of the small bowel. They're found as multiple as well. That's one of the criteria to think about familial carcinoid. We have not found why this is caused or any specific mutation of that. What we know is that usually familial carcinoid is not as aggressive as the what we call sporadic, that we don't know the cause of neuroendocrine tumors. So one factor could be familial causes. We also trying to understand that whether there is any epigenetic changes, meaning when we are born, we don't have any mutations, but then as you get older, you start acquiring mutations and mutations and mutations. It doesn't mean that these mutations that you acquire over time will make you a risk to develop tumors, but that's something that we're trying to understand, like what of those mutations acquire over time and which ones are the ones that may be associated with neuroendocrine tumors. So that's something that's still a research question, and what it causes, whether there's any changes within the genome that over time put you at risk to develop neuroendocrine tumors, and how is this environmental or there is other causes. That's something that we're trying to understand, but it still is a research question. I think yes. I think that would be my answer. I don't know if Dr. Sharon, do you want to ask anything more?
And this is great answer. Unfortunately, we don't have an answer to all NETs yet. Luckily for us, these familial kind happens only in minority of cases, but that's true for most cancers. Breast cancer, colon cancer, skin cancers. A majority of cancers, we don't know why they happen. Very few cancers we can tell what causes them. Alcohol and liver cancer. HPV virus and cervical cancer, smoking and lung cancer. So there are literally few examples I can count on my hand, but 99% of cancer, why somebody developed this cancer or that cancer, is really no primary reasons. It's a random mutation, an error the body makes. Hopefully we will figure it out someday and then we can screen for it. All right, moving on. How can a technology make a scan better or worse? Maybe I can take that one. We don't have a radiology colleague with us today, but so this is a very common question. What scan to do? Is PET scan always better? Should I get CTs or MRIs? Very, very common questions in our community. So I want you to know each scan has its own strength and merits. Every patient should get a PET scan for well-defined NETs called a DOTA-TATE PET at baseline. I try to repeat it anytime there has been a significant change in status of disease. Either there's a growth on the CT or MRIs or clinical progression. So that's when I get the next new baseline. But CTs and MRIs is how we monitor the cancer. Because PET scan does not give us the measurement, as Dr. Henderson mentioned, it is really good in picking up hidden disease. Something might be hiding in bones, a lymph node, some obscure area, and PET scan can light up wherever it's a full body scan. But if we have to monitor how the treatment is it able to control the disease or not, and for that we need to measure the tumors. Is the tumor shrinking or growing? For that you need what we call cross-sectional anatomic image. That's just a fancy medical jargon for CT or MRIs. Okay, so CTs and MRIs, because we inject a contrast and it gives us a nice border around the tumor, so we can actually measure it. And that's how we know, okay, the tumor was 1.6 centimeter 3 months back, now it's 2 centimeter, clearly grown. So how do we pick between CT and MRIs? They're very interchangeable in my eyes. Certain organs certainly can be better served with specific scans. For example, MRI is more sensitive for liver. But a usual case, do we need to put somebody through a long MRI because if you're claustrophobic, there are a lot of practical issues with it. And if it's easily measurable lesion on CT, you don't have to go through it. But if you have very diffuse disease, it's very difficult to assess on CT, MRI is a very sensitive scan. But is MRI always good? No. So if we are looking at bowel, the air really interferes with MRI because of magnetic resonance imaging. CTs are better. So no scan is completely like, oh, this is the best scan. So different tools for different patients. And we use all these tools. So can different technology can make things worse or better? Technically, yes. Because if you had a CT at the baseline and then you repeat it with an MRI, and MRI is a little bit more sensitive for liver, you might catch a little bit more disease. But in the larger, grander scheme of things, it's not a big change. You're not going to miss that much amount of disease on a CT. So once you pick your scan, I try to stick with that because it's apples to apples comparison, unless there is a specific need. Some people have contrast allergy. You cannot give iodine to that patient. You won't do a CT scan. Then you have to do an MRI. And then for one time switch, there might be some apples to orange comparison, but moving forward, then you'll stick with MRIs. So those are some real world scenarios that we have to. Between the PET scans itself, now we have various type of PET scan, the gallium dotatate and the copper dotatate. And they have a very slight difference in their sensitivity. So you might have one scan, usually copper, pick up a little bit more disease because more sensitive. But these are not really seismic changes that's going to trigger a lot of management change. These are 19, 20, 21 differences. Okay, so we take it with a grain of salt. Next up with Dr. Gaivala, what are long-term quality of life side effects after the surgery? How common are they? I'm going to club a lot of surgical questions here with that. And then how can we advocate to reduce these complications? What kind of questions should a patient ask the surgeon?
Sure.
Surgeons usually have like a, what do you call, bad rep for being very, okay, my way or highway. Not her, she's wonderful. No. But what are the kind of questions that the patients can politely ask the surgeon without kind of making them intimidated?
Oh, yeah. Well, it's a great question. One of the, key points that I try and include on my slides are the importance of the patient's wishes and quality of life. So whenever we are talking about surgery, it's really important not only to make sure that the surgery is the appropriate treatment for that patient at that time, but also that they're aware of the risks and benefits of the surgery. So patients, for whatever reason, may not want to take on the risk of the operation. So depending on if we're talking about a liver surgery or a pancreas surgery or bowel surgery, the risks are going to be specific to that operation. In general, there's risks to general anesthesia. So patients are at higher risk of complications if they've got significant heart disease, if they're on blood thinners, if they're on immunosuppression. Patients who are undergoing liver surgery, for example, may be at risk for bile leaks, infections, hernias. There's a number of different complications that can arise from the surgery, as well as quality of life issues that can happen after surgery. An example of a quality of life issue may be bowel resection. So if we're removing a portion of the colon, patients may suffer from significant diarrhea after surgery. So there are a number of patient-specific and operation-specific quality of life issues that may be unique. I really think it's the surgeon's responsibility to be giving you all of the information, but certainly if there are questions about the steps of the operation, what to expect during and after surgery, how long recovery will be. It is very appropriate to ask those questions, and no need to even be polite about it. I mean, this is just part of the doctor-patient visit. We should be talking very openly about these things, because the worst, you don't want to have any surprise. We don't want there to be any surprises. We want you to go in really prepared and, in a way, being an expert in what that operation is and what life is going to look like afterwards.
100% endorse that. You cannot offend us. I've had times, so one time I just went a little crazy and trimmed my beard a little shorter. So I went to see this new patient and they thought I'm a medical student. So I had to reassure them. My first publication in NetSource was probably somewhere around 2011-ish. So I've been doing it for a few years now. But you don't offend us. Please clarify you want to be seen, and at the end of the day, it's your body. You have to advocate for yourself. So you kind of get that, and no doctor is for everybody. You have to kind of find the right fit for yourself. I agree with you. All right, next up. Oh, this is an interesting question. Dr. Delaware, why don't you take this one? So we heard about serotonin. We also know about SSRIs, the mood elevating drugs. So there's always this confusion about, can these SSRIs makes my carcinoid syndrome worse, and the vice versa? How does carcinoid syndrome affect my mood, etc.? So why don't we tackle all of this together? Dr. Delaware, what's your take on usage of SSRIs in neuroendocrine tumors? Any data, long-term, short-term, and very important question.
Yes, that's a very good question. And we actually published last year an article. It was a white paper with our North American Neuroendocrine Tumor Society about palliative care, and as well as some discussions about end of life and so forth. And one of the things that we discussed was about some of the common questions that patients ask. That is a very common question about whether using a serotonic reuptake inhibitor, which is used for depression, anxiety. A few names, for example, would be like Effexor, Lexapro. Those are some of the medications that is used for depression, anxiety, hot flashes as well. When we were doing the review, we saw that there's two studies that they did in neuroendocrine tumors, where they, a cohort of patients where they gave SSRIs and another cohort where they did not get SSRI, and there was really no difference. So meaning that based on the studies, SSRIs is safe to use in patients with neuroendocrine tumors. It's not going to make the disease worse. And to the contrary, if it's needed in patients that have depression, anxiety, I think it will be quite helpful. Now, what I sometimes recommend on patients is, like, for example, if they have hot flashes and lanreotide doesn't help, and low neuroendocrine tumors, small bowel neuroendocrine tumors, the short-acting octreotide doesn't help. I have recommended Effexor. And that seems to help a lot of the hot flashes, because it can also, some of the hot flashes could be multifactorial as well. And we usually recommend Effexor to help with hot flashes in patients. Female patients are postmenopausal, even also in breast cancer patients as well. So I think it is safe to use SSRIs, and is indicated even in some patients with neuroendocrine tumors when they have hot flashes. So I don't think this is something that it would be negative in any way. And there has been studies that have proved that as well.
Wonderful. That's very reassuring to know. Thank you, Dr. Delaware. The same patient is also asked, any studies for somatostatin receptor negative tumors, and what percentage of tumors move from the non-functional, that means they are not secretory, to secreting kind? So just a quick clarification for the unversed. We heard about different ways that we classify neuroendocrine tumors, right? We have to be unique, right? We are not easy as colon cancer. So neuroendocrine tumors can be classified based on origin. You have a gastric NET, pancreatic NET, lung NET, can be classified based on the morphology. You have a NET or the neck, neuroendocrine carcinoma, so well-defined neuroendocrine tumor. You can be classified based on the grade. You have grade 1, 2, or 3. You can be classified based on whether the tumors are secreting hormones or not. Those are called functional neuroendocrine tumors, those the kinds which are secreting hormones, like Dr. Delver mentioned. And the non-secreting kinds are the majority, about 80% of those, which are just causing problem because of the fact of tumor growth and causing problems with metastases. So they are not really secreting any hormones. So the question is pertaining to that, what percentage of tumors really switch from being non-secreting to secreting? I can get started, and then maybe Dr. Vigela can add to it. My experience, I don't think we have a lot of really good data, but my experience with this disease is if you have a non-functional tumor, you stick with that trajectory. Now, sometimes the confusion arises because they always had the functional tumor. That means it was a smaller tumor, it was secreting serotonin or whatever hormone, but it was getting metabolized by liver or some other organs, and patient was asymptomatic. Once patients started developing liver metastases and burden of disease in the liver, they were not able to metabolize that hormone. And now your blood has high levels of serotonin, and now you're becoming symptomatic. So you would think, oh doc, I would non-functional to begin with, now become functional, but wasn't the case. It's just the burden of disease in the liver is now overwhelming, and you are seeing more exposure of serotonin or the particular hormone on the other side of the liver, the systemic circulation. So that is a very common phenomena. So patients start with small disease, asymptomatic disease, and as the cancer progresses, especially in the liver, the only exception to that is ovarian neuroendocrine tumor or ovarian mets, because ovaries have blood supply that can bypass liver. So you don't have to have liver mets there and still be symptomatic. But that's the common phenomena. Would you agree with that?
I agree. I do think sometimes patients may have had symptoms and not realize it's related to their neuroendocrine tumor. Sometimes it might be from a structural phenomenon, maybe some crampy abdominal pain or non-specific symptoms, but more likely they've been having some symptoms of hormone excess but just didn't realize it until they learned more about the disease and were undergoing evaluation and treatment, and then realized that, oh, it was probably this all along, rather than it being non-functional versus functional.
Gotcha. Anything to add?
I do want to make a comment, because if the question is like it was non-functional and now it's functional, I think it's important to also recognize, even though it's very uncommon to see that, I think it's important to recognize this phenomenon called paraneoplastic syndrome. So what that means is that paraneoplastic means that any cancer we see in any type of cancer, and basically what it is that cancer is producing hormones that was not initially there. That's what paraneoplastic syndrome is. And it could be chemicals or hormones. It doesn't have to be necessarily hormones, but that can happen. We see it sometimes in pancreas neuroendocrine tumors that they may be not functional, and over time they start producing ACTH. And like I discussed earlier, ACTH stimulates the secretion of cortisol, and now we have this picture of Cushing's syndrome, and we need to treat that. A lot of the time is to removing the stimulus. So even though the tumor is producing ACTH, if we remove the adrenal glands, there is no stimulus. That's usually my recommendation when that happens, but in the beginning, maybe some medicines. But as you can see, it's a series of symptoms related to Cushing's syndrome. But that's something that we need to keep in mind. In small cell lung cancer, also we see that as well. And sometimes we have seen, very rarely as well, that they can produce growth hormone as well. So that's also very uncommon, but that can also produce growth hormones. Growth hormones in somebody who is an adult, it can cause a syndrome called acromegaly, so meaning that you start having increase on the circumference on the head, the hands, sometimes it can affect the heart. So it's kind of like in adult, once the bones has fused, meaning that there is no more space to growth. In acromegaly, people start growing this way, and before that, they start, kind of like giantism, start growing that way, but that's in pediatrics. But that's very rarely occurring as well. Sometimes I have seen that very rarely as well that we have a pancreas neuroendocrine tumor. Sometimes that may also co-produce another hormone too. And that's something that we need to understand what is the size of symptoms related to that. In MEN1, we have seen also pancreas neuroendocrine tumors that produce gastrin by the same time, because MEN1, they can also have different neuroendocrine tumors appearing over time. And then maybe also having a lung neuroendocrine tumors or type-make neuroendocrine tumors, and that may produce another hormone as well. Sometimes we see a gastrinoma, and that is producing gastrin, a pancreas neuroendocrine tumors that is non-functional. So that's the reason for MEN1 we have a different screening criteria to also make sure that there is no other tumors associated or neuroendocrine tumors associated with that. But yes, it can happen. Just rarely, but it can.
Exactly. So see, that's why, you can never say never in our field, right? So no single rule applies to everybody. So you always have to have a little bit wiggle room for exceptions. Right. So those fortunately are exceptional cases. I don't know if some of you probably know one of my old mentors, Dr. Eugene Woltering. He is big time surgeon. He's now retired and he's been in field for 40 plus years. So my earliest neuroendocrine cancer publication was this really rare case where we had a pancreatic net who started as a grelinoma and over the years converted into insulinoma. So we see all sort of these exceptional rare cases, but of course we have to factor in individual patient history and clinical information and then have discussions with the physician. But in general, you don't really see those kind of switches, but always have, food for thought for those sort of situations, paraneoplastic or different primaries or MEN for sure. Okay, great. Fantastic. Dr. Vigabella, what is the rate for recurrence of tumor after debulking surgery? Let's talk about early stage cancer and then stage 4 disease with debulking. How fast does the cancer come back, or are you able to cure it with surgery?
So generally for localized disease, we're often talking about cure. I always leave that open for long-term surveillance. So in my personal practice, I don't ever like to cut the patient loose, and even if I am saying that you've had a curative surgery, because we have seen those patients with localized tumors come back with metastatic disease or recurrence. For stage 4 disease, debulking operations, you can kind of think of that operation as resetting the clock. So generally and a lot of the studies that have been done have been retrospective studies with mixed patient populations. So it's a little hard to tailor it to one specific patient group. But in general, it's for the well-differentiated patients with stage 4 disease that has metastasized to the liver. In those patients who are good surgical candidates, you can kind of think of it as resetting the clock, where you're removing all visible tumor, but there will be microscopic disease that we can't see that remains present. And so we do expect recurrence, and it has been reported to be as high as up to 80% at 5 years and up to 99% at 10 years. And so it can happen. We do see it, and that's why we have all of these other tools that work for neuroendocrine liver metastases that we talked about today. And so surgery is just one of those options, and it may be the right option for one particular patient, whereas another treatment modality may be optimal for another one.
Can I add?
Absolutely.
Can I add something?
Yes,
Yeah.
yes, please do.
So I think it's important also to differentiate what Dr. Vadiwala is saying. When it's only localized disease versus metastatic disease. So localized disease is only in small bowel, is in the intestine, it's only in the pancreas. Usually the indications for pancreas surgery is when the tumor is 2 centimeters or higher in order to do surgery. Less than 2 centimeters we just observe with scans. But I think it's important to recognize localized versus metastatic. localized tumors, there is a different risk of recurrence, whether it's the lung, pancreas, or small bowel. And that's the reason why it's important to do scans up to 10 years. Usually what I do is I do scans, more frequent scans in 2 years, and then after that, every year up to 10 years. Because it's true, there's a risk of recurrence as well. The highest risk of recurrence we see more with pancreas and lung. Now, with metastatic disease, and maybe Dr. Batiwala, please confirm that is never 100%.
Correct.
So because you're going to still see there's still going to be microscopic disease that the surgeon was unable to resect. And those are the things that we need to monitor over time. So in metastatic disease, unfortunately, it's not like we're looking for recurrence because the disease is already outside of the primary origin. So already it's metastatic, we just need to follow on until there is something that we can see in scans and that we can treat. So there is no recurrence, there is unfortunately there. So whether localized, yes, localized disease, there is a risk of recurrence, and then we just need to follow over time with scans. Does it make sense?
100% agree.
Yeah.
That's why early detection is the key, guys, okay? If you detect it early enough, and we can get it early in stage 1, stage 2, stage 3, our wonderful surgical colleagues, and sometimes even before that, a lot of NET patients are diagnosed on endoscopies and colonoscopies, okay? And it's in a polyp stage and they resect it and don't even need surgery sometime, okay? So early stage, surgery, cure. Late stage, still role for surgery. That's why we have smart doctors like Dr. Vega and our tumor boards to help us, can that patient get surgical debulking or not, and then kind of go from there. How does carcinoid syndrome impact tumor growth, and what diet and how do patients get protein in the carcinoid syndrome patients? Because, you know, tryptophan, essentially amino acid, and risk for increased serotonin. Why don't you answer that question together?
Yeah. Yes.
Great question.
Yes, absolutely. That's a very good question. And I mentioned earlier too during my talk that there are certain food that can, like Dr. Chauhan said, there is a tryptophan is essential amino acid that's from certain food that, you know, in day to day, and some of them is like you say, protein, meat, and turkey, and all that. That said, I usually tell my patients, I don't want you to deprive the things that you like to eat. Everybody's different, and especially for patients with neuroendocrine tumors, when they're getting lanreotide or sandostatin and all those medicines, that is definitely going to help with that conversion from serotonin to 5-HIAA. So I think that I definitely don't deprive patients to eat certain food, especially if they like it, if they enjoy it. I think everybody's different. Most of the time, what we see is that they worsen the symptoms. That's something like is temporarily. But is that said, you know, just continue watching what you're eating, seeing what your body is more sensitive to, and maybe you can take certain measurements. But at the same time, I do want to clarify that I don't want any patient to deprive themselves of the things that you want to eat, especially protein, because protein is needed. Like, for example, whenever a patient is going for surgery, for cytoreductive surgery, I tell them eat protein, walk a lot, so that way the recovery is faster. So I think that's important. So I don't want you to deprive the things. You just need to be mindful of what things can worsen the symptoms and watch, you know, because maybe for some patients, maybe wine, for some others, not at all. I don't know if that answered the question.
Absolutely,
yeah.
absolutely. See, one factor that is common for all cancers, not just neuroendocrine cancers, the patients who do the best are the ones who are the fittest. Biggest part of fitness is nutrition. So if you deprive your body of nutrition, you will lose weight. If you lose weight, you get weaker and you'll have worse outcome. We know that across different cancer types, it doesn't matter what cancer we're dealing with. So a very common question I ask my patients, is weight stable? They think I'm asking casually, but it really is a red flag. If they're losing a lot of weight, we need to fix the situation. Are they losing weight because they're not eating enough? Is it they're devoiding themselves of protein or high nutritious food? Or they're eating enough, but they're having carcinoid diarrhea or absorption problem, lots of stuff. This is a whole science in itself. And we try to plug them with the nutritionist and most NET centers have a nutritionist. Actually, this is a good segue to a question: how do we vet our NET specialist or program? Dr. Heffenderson sort of alluded to that. You know, there are a lot of states, unfortunately, it doesn't have any NET specialists at all. And then I'm seeing patients from, like, you know, across state lines from those. So I think having some NET specialists supervise your care along with your community oncologist is better than having no NET specialists. But let's suppose you are spoiled for choices and you have multiple options. How do you pick one? How do you vet a NET specialist? We don't have any guidance regarding that. ENETS, European Society of Neuroendocrine Tumors, they do have a classification, the ENET Center of Excellence for European sites. But US, we don't have, and NANETS don't endorse anything right now. But just some of the common things would be that the provider that you're seeing is focused on neuroendocrine cancers. So it's not that, oh, you're typing Aman Jahan and majority of papers are showing up are ovarian cancer, right? So that would be weird. So that's one of the things. You want the person that you are seeing has a team equipped to provide a multidisciplinary care. So you can't run neuroendocrine cancer program as a solo practice somewhere middle of Iowa. Not Iowa as a bad example. Iowa has the best program. You know, somewhere in a small town, because you really need a smart surgeon, you need a geneticist, you need access to nutritionists, you need access to the whole team, interventional radiologists. A lot of patients had questions about histotripsy, Y90, all this. So one of the questions you can ask your provider, do you have a neuroendocrine tumor board where you discuss? And that means you have access to all of these key components, right? So those are some of the indirect ways to vet your program, that you have all these tools. Last but not the least, we all see each other's patients, right? I've seen patients who are coming from Memorial Sloan getting MD Anderson, you name it, Dana-Farber, and I bet my patients have gone to all these places as well. There's no common denominator that, you know, somebody would always find, oh, I didn't like that doctor, right? So it's not that that doctor's not good. And I'm sure I don't even look at the Google reviews. I don't know what I'll find there. But it's just a match of personalities. That's why medicine is not a perfect science, it's an art. It's how you click and what kind of relationship you share. So it's a possibility that you might be seeing the smartest doctor, but you don't it's not personable to you. And that's not a doctor problem, or it's just not a good match problem, right? So, you know, but at least if you are able to see NET specialists, and there are some websites that will list, Carcinoid Cancer Foundation used to have, but I don't know how updated they are right now. But those are some of the ways that NANETS, I'm co-chair of NANETS Communication Committee, and this is one of our tasks for this year, to kind of make a website which will list by the state what NET specialists are around, so we do some sort of vetting, okay, at least have published 10 papers, that's a very low-hanging fruit, have all these things. And then patients who are in Georgia don't have to come all the way to Florida, if there is somebody nearby. So we're working on that, guys. How much time do we have? I think we have to shut down at 4 more minutes, so let's kind of keep going, guys. So only good reviews for me, that's what I meant. I'm kidding. I've heard neuroendocrine tumor patients are at higher risk for developing other cancer. Can you expand on this? Dr. Del Rivero, is that true?
Just a little bit of a background, and that's also a very good question. So Dr. Julie Hallett, who is also a neuroendocrine tumor surgeon. She is in Toronto, Canada. A few years back, she published a paper where she described that neuroendocrine tumors may be a risk to develop other cancers. So basically what she did is what we call epidemiological study. She looks at all of the patients, thousands of patients, look back and understand whether there is a possibility of a risk to develop other cancers. And if I remember well, Dr. Shahan, maybe you're more updated or remember more of the data related to that paper, but basically patients that had gastric neuroendocrine tumors may also have a risk to develop esophageal cancer. If they're appendiceal, I believe it was more like colon cancer, possible liver cancer. So, but I think with all of that, since neuroendocrine tumor patients have been have scans over time, so that's certainly something that if with the scans we can detect things earlier. I have seen, at least in the cohort of patients that I have seen patients where they have neuroendocrine tumors and kidney cancer as well, and develop kidney cancer, but we are able to detect those earlier with all of the scans that we do. Colon cancer is another one, but we have guidelines to do colonoscopy anyway as well, so we still need to follow the guidelines needed for screening, like mammograms for breast cancer, colonoscopy for colon cancer, pap smear for cervical cancer. So any patient needs to follow the guidelines, screening guidelines for that. But based on what I recall from Dr. Julie Hallett, yes, I mean there is some increase on liver, colon, and rectal, and esophageal, if I remember well. But yes, I mean there is some relationship there. That said, I don't want you to get scared because it's not something that we see very often. And that said, we do scans, lifelong scans with our patient with neuroendocrine tumors, especially in the metastatic setting. That if there is something that we see, we should be able to detect it earlier. I don't know, Dr. Chauhan.
I may have a little different views. It's always fun to have a little bit different views, right? Otherwise, it's all boring. Dr. Julie Hallett, who is also in town actually for a surgical meeting, wonderful surgeon, smart surgeon from Canada, doing a lot of really interesting work and great work advancing our science. This particular study is an observational study, right?
Yeah.
So you kind of look back at all the data, and one golden rule you have to think, correlation is not causation, right?
Yeah.
So when you kind of, let's suppose I say, it's the same study I pick, all the people who have blonde hairs also have high risk for colon cancer. A lot of those thousands of patients, at least if you're looking in the US, will have blonde hairs and have some sort of cancers. Is it linked? Just because we observed it, are they truly linked? So the unique thing here is because neuroendocrine cancer is an indolent disease, many of these cancers are caught very early. Actually, bulk of neuroendocrine tumors we don't even see. They don't come to me. And a gastroenterologist does an EGD or a colonoscopy, finds the polyp, takes it out, gone. In the books, has a neuroendocrine tumor diagnosis. But it is benign, it's cured, they don't even ever have to see a neuroendocrine tumor. But in future, this patient ever has anything, even sneezes, that gets recorded as a neuroendocrine tumor patient has sneezed, or had COVID, or had colon cancer. So you have to take these observational data with a huge chunk of salt. So I'm not convinced that there is high risk because we're going to scare a lot of our patients, right? So we have to, I think it's good to study these and encourage our scientists and physicians who are studying these so that we can grow. But right now, I don't think the data is as clear for Teflon causing myeloma, right? That's the degree of studies that we need. Or smoking causes lung cancer. You know, so the data is not as powerful yet. I don't want to unnecessarily scare you guys. So we might disagree a little bit.
No, I completely agree with you. No, I completely agree with you. I mean, I like what you say about, what do you say? Because
correlation,
is not causation. I completely agree with you. But, you know, there is a study and, you know, and as we know, it kind of like sometimes it's a common question, especially when we have an
expert. And it can scare people.
Yeah,
so very valid question.
But if I can say just one quick point. Now, familial syndromes, that's a different story.
Oh, yes.
Yeah, so familial syndrome is a different study because we have patients with VHL that may have a pancreas neuroendocrine tumors, but also may have kidney cancer, also may have pheochromocytomas and paragangliomas, CNS hemangioblastoma. We have the men one that may have different type of neuroendocrine tumors to metastasize. So you have the NF1 that they can have pancreas neuroendocrine tumors, but they also have brain tumors, malignant peripheral nerve sheath tumors. Those are different stories. So we know that those patients that have familial syndrome are at risk of multiple cancers, but that's the reason why we have surveillance scans to do that.
Right.
Yeah.
And when any neuroendocrine cancer patient is seeing a provider, especially an specialist for the first time, it's important to capture that family history. Are you at the risk for all of these things, right? Because majority, patients will not. It's 1 of 10 maybe, right? But if you are 1 of 10, then you really need a detailed, thorough workup. You might even have to go see Dr. Del Rivero. But
Yes,
for
sir.
majority who don't have any familial predisposition, no genetic risk, which is 90% of cases, we don't have to worry about all of this. And family history and personal history is the best screen to
Yep.
tell us whether you have those red flags or not. Do I need to send you to geneticist to get checked or not? Okay. We have no time left, but I'll just answer one quick question. Was one of our studies, did the oral somatostatin analog pill, did that study the outcomes? Did it include tumor control? No. So that study was testing carcinoid syndrome control. So again, our main tools, this lanreotide and sandostatin, a great drug, are the approved tools for tumor control. But this is a good start for us. We have found a pill which controls the carcinoid syndrome. We have yet to test, does it also control the tumor? That is yet to be answered. This study was not designed for it. So all the patients who were included in the study had stable disease, had by definition non-progressive cancers, okay? With that, I'd like to conclude, but somebody asked me a wonderful, wonderful question. Dr. Vigavella, since you're coming and joining us, will you root for Hurricanes or still Gators? Well, thank you so much for your time and your patience.